All right, we're going to go ahead and kick off. Hello, everyone. Welcome. Buenas tardes. Good afternoon. Welcome to Breakout number 3. Before I move on, get too far ahead, I want to call your attention to the screen if you require interpretation. Si requieren interpretación, favor de utilizar la información que se encuentra en la pantalla. I can't say it in other languages, but I hope that, we're putting that information in the chat as well. If you all have questions, you can shoot them Vincent's way. Vincent's our TA, as is Andrea Mackey. Thank you both, CPEN staff. And all right, so we are in breakout room number 3, protecting the integrity of emerging workforce models, community peers, community health workers, and promotores. My name is Rosa Flores. My pronouns are she, her, ella, and it is my pleasure to be here with you. I am the Director of Programs with the Latino Coalition for a Healthy California, a sister policy advocacy organization to CPEN. A little about myself. I'm the proud daughter of once undocumented ag workers who migrated to the US from the southern region of Mexico back in the 80s. I was also born and raised in the US-Mexico border region, so I'm very much transfronteriza. Even if I do live in Sacramento, I carry those experiences with me always. I'm also a community builder who finds deep joy in elevating the power and voices of particularly women and youth of color. So it is my honor and privilege to be your moderator for today's panel. I believe good things come in threes, and we certainly have 3 very powerful and dynamic speakers with us today who are here and ready to share their experience on the workforce model that is community health workers and promotores. So without further ado, I'm going to have our panelists go ahead and introduce themselves. And I believe we are going to pin them, right? I'm not sure if they're showing on my screen, but we have, I'll have Licia go ahead and take it away.
Oh, okay. Good afternoon, everyone. My name is Licia Harrison. My pronouns are she, her, and hers. I am located in Stockton, California. I am the executive director for Be Smooth Inc. However, I wear several hats. I'm also a clinical supervisor for San Joaquin Pride Center, also working as a mental health clinician for San Joaquin County Behavioral Health and in 24-hour services for crisis, and have a private practice for therapy. I have lived in Stockton, California for about 30 years now. I've been working as a social worker for about 20 years. And so that is where my true passion lies, in working with individuals, families, and within the community. I'm always wanting to advocate and really work to educate others on how to advocate for themselves, their families, and the services and or resources that they need. And so I'm not always the most expressive person, but I am truly very passionate about mental health services, particularly in the Black community, and trying to, I know there's another group, but trying to help also eliminate some of the stigma associated with accessing mental health services in this community. So thank you.
Thanks so much. Amina? Amina, would you like to go next?
Sure. Thank you so much, Rosa. Again, my name is Amina San Matthews. I am the program director at the Cambodian Family Community Center. The center is located in Santa Ana in Orange County. We're a grassroots CBO who's been around for over 40 something odd years. right smack in Santa Ana. I'm the program director, as mentioned, for our health and mental health programs. A little bit about myself. I was born in a refugee camp in Thailand. My family and I immigrated here about 40 something odd years ago and settled in Santa Ana. I belong to, the small little ethnic minority group that called the Cham group. We've been there for 40 years and what else? A little bit of more stuff about myself. I'm a mother, wife, sister, and auntie. Um, my passion is in the community. I've worked in the community, almost half of my career. Before community work, I was a teacher. I taught out in East Palo Alto. Forever, teaching is always forever in my heart. I'm also now a therapist as well because I understand the importance of mental health now, and that's why I went into mental health because we need more folks in the mental health field who can speak the language. We're looking for a Cambodian speaking therapist, and you know how hard that is to find a Cambodian speaking therapist who can help our elders. They're getting old in age and they need our services and our support. And we need folks who understand, not only understand the culture, but also understand and speak the language as well. So, mental health services events like these really touch my heart and reminds me on like an everyday basis why I do the work that I do. My heart and passion is in the API community, specifically the immigrant and refugee community. So thank you very much for having me here today, Rosa.
Thank you. Thank you for being here. I'm getting chills as I'm hearing you all present yourselves, and truly what an honor to be here and share space. Natalie, last but certainly not least.
Thank you, Rosa. Good afternoon, everyone. Again, my name is Natalie Santamaria, pronoun she, her. I am the Promotora Network Manager for Visión y Compromiso. And a little bit about myself. I am an immigrant from Mexico City. I was born there, and I grew up until the age of 11 years old. I had a very privileged childhood, but after the passing of my father, I was brought into the United States. I crossed the border by myself, well, alone with no family members as a young child. So I got to experience all of that as you can imagine, coming from a very well family in Mexico City, was very new and definitely traumatic. No family and no friends. So that background is what led me to the work that I do today and supporting our immigrant families that are underserved, underrepresented. I am also a promotora that advocates for the integration of the model into the workforce. Being in these spaces is a way to continue to lift them and bring along all of those that are behind us, right? We each represent community members, we each represent a story. So being able to be in these spaces and also utilize them to continue to lift up all of those stories and make sure that they are at the table and part of this policy making conversations, and that we continue to move the work together. This is very personal, as you heard a little bit of my story. This work is very, very personal. Mental health. I went through all those loopholes or not having any resources, navigating the system, learning English. And when my mother was able to join me here, also serving as a navigator for her, as many of us as young children or adolescents have had to do and still do, right? Because our parents keep getting older and they keep needing our support. And who better than us that provide it with love and tender, because we understand.
Thank you so much, Natalie. It certainly is hard work. Thank you for sharing, your experience and your background. Absolutely, the phrase that comes to mind is what's personal is political, right? So I just want to ground us there, and thank you all for setting the tone for the conversation we're going to have today. We're going to take a few steps back because some of our audience may be strongly familiar with the CHWP model. Again, CHWP stands for Community Health Workers / Promotores. I want to make sure I don't get caught up in alphabet soups. So some folks may be familiar with the model, but depending on the setting, whether that's clinical, whether folks are working at a CBO that does direct services, or if they're at a policy advocacy organization, the definition of a community health worker or promotor might differ. So let's start there. How does your respective organization define a community health worker / promotor? And we'll start with Natalie.
Well, for us in Vicente Compromiso, promotores and community health workers are liaisons, right? They're links between communities and health and social service providers. Many times they're highly trained community experts and trusted members of these communities. We characterize them by their servicio de corazón, or service from the heart, because we know that most of them do this voluntarily. They do not get any paid benefits from doing this, so we call it servicio de corazón. There's a lot of names that exist for promotoras, but we believe that the skills and the qualities are very similar.
Thank you, Natalie. We're going to talk about that, about compensation and some policy that's currently on the table to support the integration of those models so folks can get paid. But continuing on with how we define CHWPs, Amina, how does Cambodian family?
Well, TCF, we call them case workers, case managers, health navigators. They're superheroes in our community. They're the trusted messengers to our community members. When COVID hit and we didn't know who to turn to, community members, we had to close down our center. And we had folks who has been with us for over 30 years, and they didn't know where to go, didn't know what to do. And our health navigators, our case managers, our promotores, whatever you call them, I call them superheroes. They were the one who were at the forefront, providing information, education, empowerment, everything, and to let our community members know that we've got this. We're in it together. We're gonna do this work together. We're gonna help you get all the information you need about COVID, all the information and resources you need about mental health services. So that's how we define community health workers, promotoras, health navigators, case managers, whatever you want to call them, and at TCF. Thank you.
Thank you, Amina. Licia, what kind of work is Be Smooth doing, and how is Be Smooth defining CHWP?
So I think it to Amina's point, I think we all, Be Smooth Inc. is a very small nonprofit, but we all play a role. And how I am defining it is, even prior to being in my current role, just being part of this community and having connections with others in this community, and them knowing that I have knowledge of resources and services, and being able to take the time to explain what resources may be most helpful or how to access those resources, and sharing my knowledge with other community-based organizations with their staff, so that we can kind of spread that message. And we are creating our own network within the community. So, as far as putting a label on it, for instance, San Joaquin County Behavioral Health Services has outreach workers and, mental health outreach workers. That is the actual title. Within my own organization, I don't have anyone with that specific title, but they still do that type of work. So my program coordinator is still working within the community and providing knowledge, advocacy, and connection to resources. So I think we're all doing the work, maybe just not with that exact title. But I would like to add, just to throw this out there, is, I think maybe later we might make mention of, what is it, AB 2367? Did I get the numbers? Okay, because did I get it backwards? It really is important to have services that are linguistically and culturally relevant and representative of all members in our community. And I think sometimes we overlook that just because, we speak English, that there's no need for those culturally relevant services, but whether it's Native American culture, African American culture, across the board, I think that the representation needs to be there to make the connection to individuals that we trust within our own communities.
Thank you so much, everyone. Some of the common themes I'm hearing about the folks that are working with your organizations these are folks that understand the language of the communities that they're working in, that in fact often live in the communities that they're serving, right? And so therefore intimately understand the culture and the needs of the community that's being served. That bill that you were referencing, Andrea, thank you so much. AB 2697 is a bill that is looking to basically codify the role of CHWPs at the statewide level so that they can, so that Medi-Cal can reimburse for their services. So we'll drop some literature in the chat maybe later or follow up in an email with that. But thank you so much. And across the Latino community, African American, Black community, and the API communities, there's a lot of similar experiences when it comes to barriers and access to mental health. And we tend to approach those challenges in healthcare or when addressing the social determinants of health very similarly. However, there are also some distinct differences, right, to how we deliver the best care to our particular audiences. And we really seek to understand each other's communities. So could you share the specific role of community health workers or promotores in your communities? What does that work specifically look like in the Central Valley, Natalie? And in LA, all the areas that you're working in?
Yes, Rosa. I know Pacific Government is a statewide organization, but I do focus in the Central Valley. I think we've already alluded a little bit to what the promotor does. Again, we each may give it a different name, but they are that warm handoff to services. But they educate, they empower, they advocate for community change. They do it in a linguistically and culturally sensitive. They respond to community in ways that is relevant to them. You said it. Many of these community members, many of these promotoras are community members, right? So within their community, they're going through the same challenges, those same barriers. The difference is the opportunities they're provided with, that leadership that they're born with, right? They have that fire. It is personal, like you said, and they want to make changes. They want to transform their communities. That is the role. So whether they are in a clinical space, whether they are in an organization, or they're simply that mom that is highly involved at school that stays after they dropped off their children to talk with the moms, to talk with the parents about important subjects, right? That is when all of this really, when they start connecting and things come up. Have you heard about what's going on at school, right? Or, somebody was already diagnosed with diabetes or chronic disease. Or maybe they're even talking about, traffic when we're dropping off our kids. We're very concerned about that. And they mobilize and they advocate and they really make those changes. So that is the role of those CHW and promotoras in their communities. They're those movement shakers, they're those that are really mobilizing and getting people together to advance. I want to say a lot of the times they're the ones that are hit the first with all of, because as you're going through it and you're living this trauma or what you're going through, for example, COVID, promotoras were thinking of their neighbors. So it's, we need, when we talk about mental health, we really need to, put in perspective that promotoras are going through a lot, and there's a lot of self-care needed there, right? Because again, they were responding to community needs. They were responding to things that the government was taking such a long time to do. There were those first responders before anyone else, because they were calling and they were being creative and innovative to check on each other. You need food, you need something because you got hit with COVID. Let me find out. Let me join a webinar. Let me connect with my network and see what I can find out so I can support you. And that's who promotores are.
I'm reminded of another saying, those who are closest to the pain are often also closest to the solution. I think you just reminded us of that, Natalie. Thank you so much. Amina.
Gosh, health navigators, peer navigators, case managers, those are some of the titles for promotoras. Now, all of our case managers that we've hired are from the community. They're culturally and linguistically understand the needs of all of our community members, and they're the trusted messengers. About 10 years ago, when I came into nonprofit world and worked at my first, case manager doing outreach about mental health. It was hard. It was hard to have that conversation. It was hard to say, let's talk about mental health. Let's talk about suicide. Let's talk about how you're feeling or how you're not feeling. And it took us about 10 years to normalize conversations around mental health. That's what the community health workers do. They're the trusted messengers. They're the ones that are working in the community, on the grounds, talking to people and providing resources and empowering them to speak up and speak out, about their needs. I had one of our clients, we lost her to suicide, but she was our number one advocate. She was our number one go-to to talk about her needs as a refugee from Cambodia. She was an older adult and she needed services. And she was the first one when we said we needed somebody to come and talk to the Orange County Board of Mental Health convening. She was like, I'm there. She didn't speak a lick of English, but she was empowered to tell her story and the reason why she needed those services. And she spoke up and spoke out until we lost her recently, about 4 years ago. And she's the reason why I continue to do the work in the mental health field. And she's the reason why I became a therapist, because she needed that support. And we were trying our very best to get her the Cambodian speaking therapist, to get her that Cambodian speaking psychiatrist, to get her that help. When we started our body, mind, and spiritual wellness program, we had our case manager, health navigator, and one of our senior case manager She's really well known in the community, especially in our Santa Ana community. Every single Cambodian person that came through our center or come through Santa Ana area, or they just immigrated from Cambodia to Orange County, they know her because she's spectacular. She's been in the community working in the community for over 30 years. She's done so much work. She's that trusted messenger. If she gives you a call and she asks you to come to a meeting, or she asks you to speak up, the community members will do that for her. And that's what this one of our client, she needed. It was she. How do I go there with her? She was alone in the United States. She came here by herself. She didn't have any family. She didn't have any kids. She didn't have any, and she needed support. She needed a network, and she needed people. And we were it. She came to our center. We provided that for her. Our case manager became her daughter. Our promotores, community health worker, superhero, became her daughter, became her family. We became her family. And when she needed our help, she called us. When she was in pain, she called us. And we had to remind her that we're not open 24/7, that we can't really do the work. But you know what? Since she was our grandma and she was our mom, we had to pick up that phone call when she called us. So that was the last time she called. The case manager I was talking about was the last time we heard from her. And she decided life was too much for her and she couldn't handle the pain anymore. So those are the work of our community health workers. They're the one who become the family, the daughter, the auntie to our community members. They really do hold a space for every one of our community. Thank you.
Superheroes indeed. Thank you, Amina. Want to invite us to take a deep breath. I know a lot of these topics are very heavy, and also it's a very sobering reality, right? So thank you for holding space for our colleagues, for the pain and the sorrow, and also, the resilience. And Amina, thank you so much for that vulnerability and for sharing that experience. Again, it's a sobering reality for a lot of us. And we had talked about this before, about how particularly newly arrived immigrant folks are often lose ties with their immediate family once they arrive to the States. And so the community health workers, promotores, become that lifeline for a lot of your clients or people that come through your center. And I think that's the reality of a lot of community health worker groups across the state, despite folks not having, despite there being some limitations around 9 to 5, I've personally witnessed time and time again the commitment of promotores to answer the call after hours, on the weekends, to play the role of counselor, chef, daughter, sister. So thank you for sharing that again. Licia.
Yes, so I just wanted to start by just acknowledging that those that are doing the work in the community, that it's so important to remember sometimes that the weight, the heaviness of trying to help others meet the needs that they have, and sometimes feeling so much responsibility in getting our community members connected to the services and the resources that they need, because we see that there are so many that are lacking and so much work that needs to be done. And it does become overwhelming at times, right? Because we take on so much of that energy and pain from others. So that self-care, I know it sounds, I know it's just one of those words now, but it's really not a word. It is something that we actively need to be engaged in for ourselves, and then reminding others that are working alongside of us when we see that they're becoming overwhelmed or kind of depleted, that we are reminding them, hey, it's okay to take a break, take a step back. You know, we can't fix everything. So everything that we are doing is making a difference, and it's significant in that individual's life. But to answer your question, so, you know, the names, we've gone over that, you know, whether it's the peer navigator, peer support person, caseworker, coordinator, you know, we're doing the work. I think I'm a little biased when it comes to community-based organizations, because they are really the boots on the ground, really putting that work in. And I'm reminded that during COVID here in Stockton, you know, when of course people couldn't get out and get to the food banks like they once had, that so many different organizations whose, you know, their mission, the population that they were working on, I mean, very diverse from one another, but collectively came together to make sure that community members were getting food. You know, we're delivering food to people's homes, having drive-through pickups for food, but it was across the board, all these different community-based organizations working really hard to make sure that that need did not go unmet across the community. So I think, once again, you know, there may be different titles for these individuals and different missions, right? But collectively, when there's an overwhelming need, you see everyone come together to do the work and meet the needs of the community at large.
Thanks so much, Licia. Something you mentioned during our conversation that I made a point to highlight is that peer health navigators, community health workers, promotores, identify and facilitate points of access, even when they're practically non-existent, right? And when there's low utilization of services. We start to see that a lot when it comes to delivery of mental health, behavioral health services, because oftentimes counties have this, you know, have robust programming, but utilization is so low. So CHWPs can play a role in that. And I wanna just call us in to that point, Licia, because I felt like it was so important. Can you tell us more about what each of your organizations is spearheading in terms of elevating or strengthening the model of CHWPs and the voices of promotores? Some of you have already talked about, you know, formalizing the promotor model. I know some of you are very, you know, have very specific points about compensation. We'll start with Natalie to kick us off.
Yeah, so sorry, I did have to take a deep breath, you know, into what my colleagues just shared. But you know, in regards to Visión y Compromiso, you know, this is an organization that was started by promotoras. When our founders began this work, they just wanted to hear from promotoras and identify what were the needs. And one of the things that they asked for was an organization that represented them, and a network that they could communicate among each other across the state or wherever we would find promotoras. And so that they would not continue to work in silos, because that's something that they identified of, you know, a lot of the work, and still today, a lot of the work that gets done, you know, seems like we are in silos, especially in the center. You know, another thing that we've done is a lot of advocacy and education. We truly believe that the promotora is capable of doing anything with the proper training and education, and we facilitate a lot of that. We have a department that focuses on popular education, you know, how adults learn, learning from experience, reading what people where they are at, so that again, we can educate and continue to empower them. We've written papers and we have framework, but I think again, it's having promotoras. And what I mean by that is most of our staff is a promotor or identifies themselves as promotora. I myself began as a volunteer with the organization at one of our local committees, and having the opportunity to be employed and to be in this position where it allows me to again create the space, advocate, and work alongside with them to keep moving this model, and now providing technical support to other organizations, workforce readiness, and specific to the workforce. And, we were talking about um, all these technicalities when you start employing, which is something that Visión y Compromiso has moved to do as well, so that we can serve as a model, right? If we are saying to organizations, please integrate the model, then to us, it was logic to integrate the model within ourselves and start employing promotoras with all of the projects that we began to do. So, workforce readiness is training the promotora to understand the workforce world. A lot of promotoras, this is the first time they obtain a job. Even, from in their countries, they have not worked before. So understanding all these HR nuances, all of these things, but workforce readiness for organizations, Alicia and Amina said it's hard to tell them it's 8 to 5 because when you're a promotora, I myself find it very hard not going to a store or encountering someone and not sharing when I know of a resource or when I know I can help them. It's like in my nature. It's impossible not to do it. So understanding all those things, and a lot of the times we want to put the promotora or we think of the CHW promotora just in a clinical space. And I think we can be very innovative. And that's what we're also spearheading, being innovative, the education, the outreach can be innovative to where, again, we accommodate to the model and we really integrate it into the organization. And by all means, we empower and teach the promotoras how all this, workforce ethic and things like that. So a lot of advocacy definitely at the state and federal level as well. When it comes to benefits, when it comes to advocating for smaller CBOs to be able to apply for funding. A lot of the funding has big requirements that our smaller CBOs don't have the capacity. And we need to keep advocating for those CBOs because those are the ones that are employing our promotoras. Those are the ones that are giving these resources to the promotoras. So we need to keep advocating. Legislation is moving, yes. And you mentioned one around call aim, but let's not forget about all the other work. And again, the smaller CBOs. So that's also something that we're doing as Visión y Compromiso, advocating for the smaller ones.
Thanks so much, Natalie. You put it well. The promotora needs to know the workforce, and that's where the CBOs kind of help out. But also, the CBOs need to want to make an effort to understand that model. I think that's absolutely true. Amina, what can you tell us about what your organization is spearheading in terms of elevating the model?
Gosh, it's interesting. Before doing the work or knowing the model or understanding the model, we were doing the work. We didn't realize that there was an actual model that has been studied and done beforehand. We were always the health navigator, the case manager, the outreach specialist. We were all of that. And realizing now that all of that encompasses the Pomodoro model, right? We were doing the work without realizing that we're doing the work, and when we were talking about this, Rosa, during our check-in, and I was like, what are we doing? What we're doing here at TCF is figuring out ways to keep our promotoras, to keep our community health worker in the community. We got lots of passionate people who just wants to do the work. It's all hard and, it's meaningful work. But we also have to understand that we need to compensate them for those work, right? These folks are coming to us graduated with degrees and they've been in the community working for 20, 30 something odd years, and they can't make ends meet. You know, we really need to address that. If we're saying that we value promotores, we value community health workers, we value mental health workers, then we need to value them and compensate them accordingly. Because if we don't, we're going to lose them. We're going to lose them to bigger agencies, you know, the county, the states, or wherever, you know, because CBOs like ours, we're grassroots CBOs that's been around, but we have a limited funding, and we can do so much, but we're losing them to bigger entities because we can't pay them. But we know, I think that for us, and this is what we talk about in management and our, is how do we keep our folks? How do we continue to keep our folks here and doing the work? They have the heart and the passion for it. How do we continue to keep them here? And that's something that we're trying to strive for and figuring out. So if somebody knows, please let us know. You know, we're providing workshops, we're providing team building activities, we're sending folks out to trainings and all that. And, you know, that's not enough. So we need folks, I mean, we need, you know, bigger entities to understand the needs of small CBOs like ours. And the reason why we're striving is because our community needs us. We're that trusted messenger that without us, it's going to be hard for the state to get out the word. I mean, I'm two places at once right now. I'm attending ACBO convening for the California Public Health Department, CCHP, and I'm sitting here at this meeting as well. And same topic of conversation. You know, one is mental health, one is COVID, but it all boils down to one thing. It's the same thing, and they need CBOs like ours, community health workers, promotores, to do the work, to get out there, to get that information into people's hands. And if we're saying that we value that, then, you know, we really need to work on compensating folks who are doing the work. I think that's what one of the message I want to throw out there.
All the snaps. I mean, you're getting lots of chat. Vincent is, you know, super important to promote sustainability within community health workers and promotoras, and
Right.
agree. Yes, the struggle is real, and I think the conversation lends itself to talking about cross-sector collaboration. There's another workshop that's talking about CBO and county partnerships, right? We need to work with our government entities. Stacy, thank you so much for that information in the chat. Certainly, if there are questions around this or we want to brainstorm, there will be time at the towards the end of the session to have a Q&A/discussion. So please do jot down your questions, any questions that you have for us or any thoughts that you'd like to share. We will have time for that towards the end. Amina, thank you so much. Licia.
Okay, so I'm going to echo the comments that have already been made. You know, I don't think that it can be overstated the importance of compensation that allows people to live within their communities. And I think Stockton is a great example of people who can't afford to do this work and, you know, make a living wage for their community. I guess sometimes my fear about the community health worker is that, you know, in the community-based organizations, we are able to sidestep a lot of bureaucracy. And, you know, I want us to advocate and make sure that our community health workers are being fairly compensated, and this doesn't become something where we have all of these eligibility requirements that you need to meet in order to do this work, because some of the people that are doing the work and being most effective, you know, didn't need to go to school, right? They just this is lived experience in how they have come across how to access these resources, where to go, where the services are. And I certainly don't want that to get lost. One of the things that we're doing is in kind of bringing our youth into this with our peer support groups is identifying a lead peer support person and providing a stipend for that individual, because I think it's really important that our youth know that their time and their work and their efforts is valued, and it's you are worthy. What you're doing is making a difference, and you should be compensated for what you're doing. And so that's kind of what we're rolling out and what we're doing to bring the youth into the work and show the value of what their contributions are.
Thank you so much, everyone. All of the points that you've shared are incredibly important, and I think magnified by what we've seen throughout the pandemic. A lot of you mentioned that the folks that were at the front of the line were community health workers, peer navigators, and a lot of the demographics of who makes up that workforce are people of color, right? Are predominantly women and predominantly working class. So yes, to compensation and fair compensation at that, and making that an expectation. Thank you all for championing that across the many conversations you're having with funders and government entities. So I want to talk about how we're integrating the model, or how you all are trying to integrate the model in your local mental health departments. The collective work that we're doing through the Mental Health Services Oversight Accountability Commission project seeks to ensure that there are collaborative relationships between government and local community partners. A lot of the work that you all are doing is shedding more and more light on the CHWP model, particularly with regional decision makers who can make decisions about whether or not these models get implemented in the departments. So can you share what the challenges of integrating the model in your local mental health departments are? And similarly, if there are any successful outcomes on those conversations that you're having, we'd love to learn about those. And I'll start with Natalie, who I know is doing fantastic work in Kern County.
Yeah, without mentioning the political climate that each county can face. I am currently in Kern County, and a lot of folks call it the Texas of California. So I'll leave it at that. The many differences in definitions. I think having all this community health workers, promotores, possesses a challenge when you're talking to big entities, clinical entities like behavioral health. They want to see certification. They want to see this clinical certification. To them, if anybody's talking about mental health, they need to be certified. What studies did they go through, right? Which course, what career did they take so that they are capable, right, of doing this? So we faced a lot of that, not understanding or not even knowing the promoter model. Funding too. I think as I have worked more and more closely with the local behavioral health, it's also been giving me another perspective of the challenges they face, because they are a county entity that respond to a bigger state one, and I think that's where it all begins as well. The capacity that they have and the very little, again, knowledge or even room to wiggle at times. They also feel like they have their hands tied. So I would say the part of it is also the bureaucracy, as Licia said, and all of those red tapes that they have imposes a challenge. That's why we continue to say and lift up the CBOs, that if they were to partner with us, we would gladly and happy. We already do the work, right? So give us some funding. We'll continue to do the work and support this promotoras, but I'll leave it at that.
Yeah, and I'll just I'm gonna toot Visión y Compromiso's horn because I've had the privilege of working with them throughout the last couple of years, and they've nurtured relationships and just it's just a short period of time. They've nurtured relationships that were non-existent essentially before we started doing the MSOAC project. The contact that Visión y Compromiso and the promotoras had with the department was limited, right? And now they're being consulted as experts in how to integrate these models. So kudos to Natalie and the team in Kern County, really pushing the needle in terms of and holding the departments accountable for doing their due diligence and researching what it's going to take to fund and implement a CHWP model. All right, Amina, could you share a little bit about what's happening in Orange County?
Okay, what's not happening in Orange County?
Also, I have to say, kudos to anyone who's working in a very conservative area. As someone who grew up in San Diego County, I know the politics. Orange County is also, you wouldn't think it, but it's very, very conservative. So
absolutely, very, very, very conservative county. Gosh, for us, we're really trying to understand the model. We're doing the work. And now we really have to kind of backtrack and kind of really understand that model so that we can actually intelligently speak on the model and speak about the work that we're doing. So one of the things I wanted to bring up was, so the Cambodian Family Community Center, along with other Cambodian speaking organization in Long Beach, are part of the California Reducing Disparity Project. This is a great project because what they're saying is they're actually valuing our community defined practices. So we get to tell them these are what's working in our community. Things like spiritual activities like the water blessing, or the going to the mosque, or just going to do some meditation and yoga, or educating folks about mental health, empowering them to speak out about mental health and services. This project, I am just so happy to see it continue for another. We had it for the first 5 years, and it's going to go for another 5 years. And it's going to be a study. Well, it is a study. It's going to show the important work that we're doing right now. And these are all community defined practices that we're doing. We're saying that we're not just doing this, we're going to do a study and we're going to show you that it's going to work in our community. And it's working. If you have a chance to attend, I know there's a conference coming up. I see Stacy here. I know Stacy probably knows about that. And it's showing the state, it's showing the county that you don't need, I forgot what the other practices or something defined. I forgot the word, but anyhow, that practices work too. That we can do that. I mean, when we're talking about mental health, we don't have to necessarily continue to think the Western way of taking care of our mental health, right? Well, I'm feeling sad, depressed. Let me go to my doctor, get some medication, drugged up, or go to a therapist, sit down and talk to a random stranger, right? We're saying that may work in your community, but my community is different. We're going to need a little bit something. We're going to need something different here. We're going to need coming together around a potluck. We're going to need elders telling their stories. We're going to need the youth listening to the elders because they have so much to say. And those practices are what's being looked at right now with the California Reducing Disparity Project. And we're hoping, that another report will come out and to say that, these practices work, and we're gonna, and hopefully the county will look at these practices and implement them in their county programs and services, because right now it's not. Here in Orange County, we have a robust mental health program services. we're there if they ask us to be at that table to provide our services and whatnot. But if we're not there, we want to be able to have this be a practice that anyone can use. So that's what we're doing here in Orange County, in Santa Ana. We're trying to make, community defined practices be the norm. Thank you.
Thank you so much. Thank you for reminding us the importance of diversifying our interventions. And sometimes it takes
Absolutely.
both, right? We understand that. I also want to release the stigma around medication. Sometimes that's what it takes to get us through the day, but a combination of both, that's comprehensive healthcare, right? That's, meeting people where they're at. So thank you so much, Amina. Certainly getting lots of appreciation and +1s in the chat. Licia, can you share a little bit about how, if you, I know the work is new and you're exploring those options, but can you share even maybe something you anticipate as being a challenge when talking about the CHWP model with local mental health departments?
So I'm in that position of being an employee of San Joaquin County Behavioral Health Services, at least until October 1st. So there's not a whole lot that I can say at this time. Once I have completed my employment with them, then I will be an advocate and a thorn in their side, promoting and advocating for our community health workers. I'm just laughing at the emoji. Yeah. So until then, I do attend the monthly consortium meetings for behavioral health services, and I keep abreast of what's happening within the confines of the department. But once I'm done, then I will have more to say.
And what a treasure to have someone who knows what it's like to be on the other side, right? To now join the advocate side. I'm all about folks that can bring their knowledge into spaces like this to help us fight the good fight. We know the work needs to get done. Thank you so much, Licia, for your honesty. I'm going to move us into the next question, which some of you have already touched on, but I'm curious to know more, and that's around the topic of the impact of COVID-19. So the impact of the pandemic on people's mental health. I know we also heard a lot about that with this morning's speakers. It was a resounding theme, and we understand that COVID-19 has been devastating for our communities, the communities that we represent, and it's exacerbated a lot of the conditions, the inequities for historically underserved, underrepresented communities. How, in your opinion, how have community health workers and promotores been supportive during COVID-19 in the context of mental health? For example, and perhaps increasing access to mental health services, or any other specific example that you have. I know you all shared a lot of powerful ones during our prep call, so I'm hoping that you can shed light on that for our audience today. And we'll start with Natalie.
Yeah, so I think I would love to say that we increase access, but that's something that we're still advocating and fighting for. But what we did, and again, this is the ability that being a CBO, we have, we were given money to do the Call Hope in the Spanish side of it, which is called Estamos Juntos. So the state of California gave us money to do that part of the project. And when you're working with promotoras, you know that ideas and you get to be very innovative. So it turned out to be a statewide project where we were able to hire about 25 to 30 promotoras, and they were conducting support groups via Zoom in all different topics. Some of them were closed because they were talking about a more sensitive topics. Some of them were more open, but it went from LGBT groups, anything that you can think of. And it really allowed the promotoras again to evolve and be creative. We gave them that space to they would come to the table, that we would have meetings and say, this is what I'm seeing the need. Let's create a group. There was group for male as well, which, it's a lot more, we know that it's a lot more difficult, especially in the Latino community, for them to open up and come to see a therapist. So, it was a way to, again, respond immediately, right? We knew the access is already hard. So with COVID and with everything being closed, if they weren't already going to a therapist, they were not going to go during COVID. They were not going to go through a telemed. When you're talking about rural communities and accessibility, some of them didn't even have that, So we even had to backtrack and show them how to use Zoom. And if Zoom wasn't available, some of them utilized the Messenger app and be able to do it through there, or WhatsApp. We were able to accommodate to whatever folks were able to use. But again, just the Estamos Juntos project, which was intended for only 6 months, it was extended all the way through the last June. So we have 2 years of that project, to where, again, promotoras had support groups. And that is how we provided access to mental health. We also have in our staff a lot of folks that have been trained for alert, like suicide prevention. So we were training a lot of our promotoras, or we were reactivating those that had received the training in the past to be able to support. We brought in as one of our staffs a clinical social worker, so that they would be able to be in some of the support groups that might lead to further follow up. And we would, the last thing we want to do is open up a subject and just leave people there. We had to think of those ways. So again, we had to act just like with the food banks and with the access to vaccines, they're testing, the same thing with mental health. A lot of our CVOs were putting together this project and things that we're already the experts in, again, and a lot of them are psychologists, doctors in their country of origin. So they have the knowledge, they do have the knowledge and they have that. So they were also stepping in to support our promotoras and being able to do this work.
Thank you so much, Natalie. And you've also, in addition to those workshops that the promotoras have been leading, I understand you also had plenty of community forums across the state, really, but especially centered in the Central Valley, to continue to destigmatize the conversation around mental health. I was reminded hearing Giselle share earlier about how in Latinx communities, especially, it's normalized for people not to ask for help when they're physically ill. And you just reiterated,
Yes.
they're not going to ask for help with their, with their mental health. So this type of programming really makes all the difference when it comes to normalizing those conversations and increasing utilization of services. So thank you for sharing that, Natalie. Can you actually, before moving on to Amina, can you share a little bit too about how Visión y Compromiso is continuing to uncover ways to work with the indigenous communities across the Central Valley? Because I think that's something that's sometimes left out of conversations, right? Or merged with the needs of Latino communities, but we also have folks that identify as indigenous, and we don't want to convolute the needs of the two communities.
Absolutely. We have partnered with organizations that work with indigenous communities, and given them also the space and the tools. So we've trained some of them. But I think even changing our language. So last year we had a forum, and we were reminded that we needed to change, instead of mental health, to well-being, because or else our indigenous community was not going to come or feel welcome. And I think allowing and being humble enough to recognize that we don't know it all, and that there are spaces or there are communities where we need to partner. We do need to reach out and collaborate with those who are experts in those communities, especially the indigenous communities. And I think the Native American community is too. I think all of our communities is very close. It's only of our own. So somebody from the outside comes in, it's going to be a lot more difficult. But if that outsider is, being handheld by somebody who is from the community, it's easier for that trust to develop and be able to do it. So we've been also inviting them to take part of the cultural competence committee with behavioral health or locally, because again, once as an organization we open up those spaces, we need to bring everyone else behind us. We open the door and all of our friends need to be able to come in with us.
Absolutely. Cross collaboration. Thank you, Natalie. Amina, how have CHWPs been supportive through COVID-19 in increasing access to mental health services?
Wow. When COVID hit, it was really hard for us to close our doors because our community members depended on us for so many things, right? We were their health navigators, we were their case managers. We were there to help them make those appointments to the doctors, take them to the doctors, take them to see their psychiatrist, their therapists. And it was so hard for me to close our doors and say I couldn't send out, this was when COVID-19 first hit and everything was shut down. And it was so hard for me to shut our doors down and say, you know what, we can't go out there and take them to the doctors. We can't, take them to the social service agency to help them apply for, Social Security income or wherever. And we were trying to figure out ways to continue to provide these services, right? So everybody was going on Zoom, Facebook Live, YouTube channel and everything. And I was thinking to myself, like, a lot of our community members were elders. They didn't have the iPhone. They didn't have the iPad or the laptop. They didn't know how to get on Wi-Fi. All they had was their flip phone that they got, from the county. And we were trying to figure out, like, how are we going to do this work virtually? How are we going to provide services, mental health services specifically to our community members? And we were trying to figure that out. Then we met and we said, we're going to teach them how to use Zoom. We're going to teach our elders how to get on Zoom, how to get on Wi-Fi, how to get on hotspot, and get them on Zoom. And I was kind of apprehensive. I'm like, oh my God, because I remember my mom. I mean, she had a flip phone and trying to get her on Facebook or trying to get her on Wi-Fi and all this stuff was very hard. And so I would work with our elders. It was going to be hard. But we did it. Our case managers, promotores, community health workers got together and they created a how-to video in the Cambodian language. And they went step by step. I mean, I was so amazed at my team. I didn't know that they had that talent, because, sometimes when you're working and they outreach, they're doing case management and all this stuff, but you didn't realize they had other talents. So you had to tap into those talents. But I had my CHWs, they were amazing. They were so amazing on like technology. They put out this video in the Cambodian language that showed you step by step how to get onto Zoom, or get onto the internet and then get into Zoom and what to click. And the first time we had an event over Zoom was one of our drawing out stigma, all about mental health, sharing our stories, telling our stories. And it was a night of poetry. And it was an event that I would always cherish because we had over 70 community members log on and participated in this mental health event. It was called Drawing Out Stigma, talking about the stigma of mental health and sharing our stories. And we did it. 70 community members on Zoom, all together, listening, talking about mental health. And it was just the most beautiful event that we've held. And And to this day, I mean, it was just amazing. And so those are the kind of work that we're doing in regards to mental health. And I think Licia, was it Natalie, that mentioned the Cal Hope. That's something that we're also involved in when we were funded through our partner MECM, the Multi-Ethnic Community Collaborative Agency. They were the lead agency. We were subcontracted with them, and we were, providing trainings to our community health workers. There for that program, they were called crisis counselors. They were providers. There was peer supporters, and these were our outreach workers. These were people that we had to hire on and say, we're actually not going to do this virtually. We're not going to do this Zoom. No, you need to be out in the community. You need to be hit the ground running. You need to be out there finding the people who wouldn't otherwise know about this program. So you need to be out there. And we trained them. We provided them with all the PPEs. I mean, we've done everything that we could to get them out there. They were knocking on doors, talking to them, telling folks about this program, talking about COVID, talking to them about where to get those vaccinations, and then actively listening to them because they needed to tell their story. They were stuck at home. They couldn't go to work. They couldn't go to school. They couldn't go anywhere. They were really right there. And when our crisis counselors were knocking on their doors, they were hearing a lot of stories. They were getting a lot of stories. I mean, to this day, Cal Hope, we were done with the grant, and then the county, Orange County, picked that up. It's called OC Hope, same program, different funders, but folks, I remember our community health workers are still doing the work, getting out there into the community, going into these hard to reach community that we know would have not otherwise gotten these resources. And they were saying, I'm here for you. They're knocking on those doors. They're speaking in language, and they're saying, I'm here for you. I'm here to listen to your story. And they have the resources with them. And they know that if they need to be referred to the county services to get health insurance, to get food, if they need food, to get, the CalFresh, how to apply for CalFresh, look up, food banks. When they were going out into these homes, they didn't go empty-handed. They had lots of resources in their backpack, and they were ready to get them out, whether it was a mask or some hand sanitizers or some resources to community resources that are around them. They were ready, and each and every one of them were amazing in doing their job.
Thank you
That's
so
what we're
much.
doing, and my work is to support them. So as they're out there supporting the community, my job is to support them, to provide them a space, what's the word I'm looking for? I'm lost for a word here. A safe space for them to come back to process what they've just gone through, to decompress, to relax, to self-care, right? That's a big word right now, right? So, but to really understand what self-care means. And that's what I do for my team, because as they're taking care of the community, I have to take care of them, because I can't send them out half empty. I need to fill up their cups, and whatever ways that I can, team building, taking them out to lunch, calling a massage person, those people to come out, because they are the one that's doing the work, and we need to appreciate it and value those the work they're doing. So that's what we're doing, to uphold our community health workers so that they can provide that space or hold that space for our community members.
Thank you. That's leading with care and conviction. And what a range of skill that community health workers and promotores have, right? From mitigating those feelings of isolation that many of us experienced through the pandemic, to offering transportation to appointments, and sounds like, to being technical assistance for figuring out Zoom and bridging the divide, the digital divide, right? That is very real for particularly immigrant and LEP communities. In a world where telehealth, telepsychiatry is being pushed on a lot of patients, especially now since COVID, there's still a lot to be done when it comes to bridging that digital divide. So thank you, Amina, for those multiple examples of how CHWPs are so valuable to our society. Licia, any comments on what Be Smooth is or what the CHWPs at Be Smooth are doing during this COVID-19 time, and helping folks access mental health services? And then we'll go into Q&A, so I haven't forgotten about that.
Okay. Yeah, I know. I will keep this very brief. I think what I just kind of wanted to highlight was that during the pandemic, that it really surfaced how much inequity there is in our marginalized communities, especially when it came to access to computers, Wi-Fi, and being able to use these devices to connect, especially on Zoom, whether it was for a support group or even meeting with your doctor. And as far as increasing mental health access, not so much. I think that we all now feel the significant increase on our mental health services as a result of being in the pandemic and people being at home and being isolated and experiencing depression and isolation that we are now feeling. I mean, the need has increased exponentially for therapy across the board. Even in the Black community, you know, I see it from both sides. You know, in the private practice, I get referrals because people are looking for a Black clinician. You know, specifically, I see the increase in parents reaching out for therapy because there's, you know, prior to the start of the school year, because their kids were so anxious about returning to school and just making those social connections and not knowing what to expect. And I don't know, I feel like it's great, right, that we see that people want access to mental health services. Now we're running into the problem of we aren't able to meet the demand that there's that we're up against right now.
A critical point there, Alicia, which makes the case for why we need to invest in this workforce model, right? To increase the number of providers, the type of providers who are culturally and linguistically informed to serve our communities. Thank you to our panelists. Can I get some love for all three of our panelists who have done a wonderful job today explaining their work and also how they're meeting the needs of our communities across the state. We do have a few minutes for Q&A. I apologize. I was trying to make more time, but I think we ended up with less time. We have about 8 minutes. And if there's any questions, any burning questions that you all have, please drop them in the chat and we'll go ahead and take them. So there's one coming from Stacy Hiramoto. Hi, Stacy. Do you differentiate between CHWPs and peers, and has your county behavioral health department valued or funded CHWPs as much as they have mental health peers? And whoever feels comfortable can answer that question.
So in Kern County, we are, as we've shared before, we are just moving into having a relationship there. So they are very open to learning about the model and how to integrate it. They see an opportunity with call AIM and reimbursement because they're also facing funding, challenges. Now, I will share that Riverside County has been very proactive in integrating the model. They've given us some funding as well to hire promotoras to work specifically on mental health. I think a lot of the times they're more open to that because of all the red tape that they would have to go through. And another county is LA County that has also been very proactive into integrating the model and finding ways. So I know they hired some promotores to do like house meetings or go to schools and have like workshops on topics with the idea to start connecting them and referring them to the local mental health. Hopefully that helps.
Thanks,
Um,
Nancy. Oh, go ahead.
Sorry, I was just gonna answer Stacy's question. I don't differentiate between CHWs or peer supporters. They're the same, they're one and the same for me, because they're doing the same work. To answer your question about County Behavioral Health Department funded by or funded CHWs, they may, but it's not, but they're not calling them CHWs. The work that we're doing, like say, for example, our early intervention services for older adult program, it's a county funded program and it's a PEI program. And the work that we're doing are community health workers work, but they're called, you know, case manager, they're called everything else but community health workers. So I think, you know, what we need to do is streamline all these titles that we're putting out there because we're all doing the same work. So we can do that, Stacy. Streamline these work because, you know, when we get new workers into the field, they're like, I'm a case manager, I'm a health navigator, I'm a, you know, CHW, not realizing that they're all the same, one and the same. We're all doing the work here. So I think what we need to do is really streamline it so that when we're talking about promotores, when we're talking about community health workers, when we're talking about case managers or peer support specialists, we're talking about the same thing. So if we can all get on the same page and have county, state understand that these titles, workers are all doing the same thing, that would be great.
Same way as you. I mean, I feel the same way, but and now there will be peer certification for behavioral health departments, and I tried to get them to accept CHWs, and there was not willingness for them to discuss that. They were very upset. Anyway, so I just wondered, but then I didn't know. I go, well, maybe the community organizations really don't want the same thing. I don't know, but I do feel that the mental health, the behavioral health departments are really going to be spending a lot of time on peers now, peer certification, and they have a very rigid, in some cases, again, every county's different, but in some cases they have very rigid definitions and guidelines. Who is a peer? And again, like you said, I wish they would be more flexible or if they would streamline it, because for different communities,
Right.
You know, the cultural and linguistic and lived experience as far as being a refugee or immigrant, that experience is just as important or more important than just whether or not you have a diagnosis or not.
Absolutely.
You know?
Yep.
Really quickly, I know this merits a separate discussion, so hopefully we can address some of these on a one-on-one. Yes, thank you, Vincent, for dropping the speaker directory. There's a last question that I just want to read off, but maybe our speakers can follow up with Angela. But the question is, are you all planning to leverage the new Medi-Cal CHW benefit, that's the bill that we were talking about, and or the new peer certification process to draw down more Medi-Cal funding? If not, what are the barriers to doing so, if you can share?
Yes, definition is a barrier.
I'm going to say I plan on attempting to utilize or some of those funds. I do, once I stop working for the county,